Thank you. For the other welcome remarks, I would like to welcome our partner from UNAIDS RST, Ingrid Silalahi, which is the Regional Consultant for Young Key Populations at UNAIDS RST. Ingrid?
Hi, Rain. Good afternoon, everyone. Can you hear me? Great. Okay. Good afternoon from Bangkok. It is my great pleasure on behalf of UNAIDS to welcome you all to the second webinar of the series to bring us together to join in our efforts to strengthen community-led monitoring in the Asia-Pacific region. I want to start by acknowledging the really great leadership of the Seven Alliance, that is the consortium of regional networks of people living with HIV and key populations from Asia and the Pacific, in being able to convene and organize this great initiative in partnership with UNAIDS and also with financial support from USCDC. As Sita mentioned, and the title says that this webinar will really dive deeper into community-led monitoring, or CLM. But really, when we're talking about CLM, we're really talking about community leadership in the HIV response. And in this region, when we look at the 6 million people living with HIV in Asia and the Pacific, and the 260 people newly infected with HIV last year, we see that the most marginalized populations, that is key populations and people living with HIV, are really disproportionately affected. And simply this shows that the AIDS epidemic in this region is not over. And that's why it's really urgent for us to amplify our efforts to address the inequalities that are driving the HIV epidemic and scale up the access to essential HIV prevention, testing, treatment, and care services for all that need it. And for this to happen, communities play a critical and an essential role. As guided by the Global AIDS Strategy, ending the AIDS epidemic requires community-led responses to be integrated into all levels of the HIV response, from the planning to budgeting and implementation, and also monitoring and evaluation. Because we know and we recognize that community-led organizations are uniquely placed to understand and advocate for the priorities of their communities, to design interventions that meet their needs and really deliver them in a way that is effective and acceptable. But we know that leadership of communities expands to more than that as well. Community-led organizations play a critical role in demanding and holding leaders and stakeholders accountable to ensure that their right to the highest attainable standard of healthcare that is free of stigma and discrimination is able to be met by all key populations and people living with HIV. And that really is the ultimate goal of community-led monitoring. So we strongly call on stakeholders and our partners to support and to fund efforts like this to capacitate and enable community-led organizations to lead in CLM implementation, to own the data, to use the results to really find solutions that can find solutions and can address the challenges that the communities on the ground face. As UNAIDS, we're very pleased to support the regional networks through opportunities such as this webinar to strengthen their leadership to become providers of technical assistance and be able to provide capacity building for community-led organizations throughout this region and use their position at the regional level to advocate for the CLM value and sustainability. To conclude, we address that, we stress that in order to successfully be able to reach our goal of ending AIDS by 2030, communities living with and affected by HIV must lead the way. The task before us is to strengthen healthcare and HIV services and also deliver tangible benefits to improve the HIV outcomes for people living with HIV and key populations. And certainly at the very end is to make sure that we make a difference in people's lives. CLM is a critical way to do this. And as CLM is being rapidly rolled out in the countries of the region, we strongly encourage you to maximize this opportunity into this webinar to learn from your peers across the region and continue to strengthen the implementation of CLM in your country. We at UNAIDS are very happy to be part of this process, and we look forward to working with the 7 Alliance Consortium and USCDC further to make significant progress in the HIV response in the region. Thank you so much.
Thanks, Ingrid from UNAIDS. UNAIDS definitely has been a staunch supporter of the key population networks for years already, and they continue to support the CLM initiative of the 7 Alliance Consortium. So before we proceed to the actual discussion, may I just request from the participants to take a photo, since we're talking about CLM and we value the importance of documentation. So just take a quick photo if you are comfortable to turning on your cameras for a quick 1 or 2 snaps, just for documentation purposes, please. And I'll let our colleagues from tech support upcom to do the job.
Ready? 1, 2, 3. One more. Turn on your camera, please. 1, 2, 3. And again, turn on your camera, please. 1, 2, 3. Thank you.
Thank you, everyone. Feel free to keep your wonderful faces on the board for us to see. So thanks, Tita, again, and thanks, Ingrid, for already providing a very thorough introduction about this session. And this is definitely a follow-up and a building on to the yesterday's webinar, wherein we were talking about basics of CLM, concepts, principles, frameworks, and actually providing country models of how CLM is being implemented. And definitely people were engaged in sharing their CLM work and vision and opportunities. And this serves as a solid foundation for today's session. And as mentioned by Sita, this session should be seen as a progression on how we will be tackling issues related to CLM, its cycle and its phases. And definitely in this first cross-learning session, we will talk about how we ensure that CLM is community-led, community-owned, and basically the examples coming from our communities. We'll talk about the first phase, which is about setting up, designing CLM mechanisms, what were their experiences, their best practices in doing so, and how they did tackle issues and challenges and barriers relevant to setting up and designing stage. And the other phases of CLM definitely will be a topic and focus of succeeding CLM webinars that is scheduled in the months of June and July. So if you might be asking how these webinars will progress, we will tackle specific issues or phases in each of the webinars. We have 4 community speakers who has different experiences in their CLM programs in Asia Pacific. I would like to introduce our speakers first. The first one is Wangda Dorji, who is the Executive Director of Laksam in Bhutan. He is a dedicated founding member of Laksam and he has worked with the organization for almost 10 years as an active community advocate. Laksam, as the Bhutan's network of people living with HIV and AIDS, works closely with other key groups in Bhutan for an effective HIV and AIDS response. And another speaker from Bhutan is Tenzin Gyaltshen, which is the Executive Director of Rainbow Bhutan. Tenzin has been with Pride Bhutan since 2015 until he assumed Executive Director in 2019. Pride Bhutan has been recognized as a key player of the national response on HIV, and they have worked towards promoting well-being among the SOGSC and KAP population in Bhutan. The third speaker is from Nepal, Sarah Thapa Magar, from the National Federation of Women Living with HIV in Nepal. Sarah is an activist from Nepal and is the president of the federation and is actively advocating for the needs and rights of children, young people, and women living with HIV. Sarah has years of experience fighting for young people, women, and girls in all sectors, and she is an activist and believes that education is the key to bring change in the society. And the last but not the least, of the speakers, of course, is from Indonesia, from Jaringan Indonesia Positif, which is Bryant Sabur. Bryant is currently a plan and monitoring and evaluation officer in JIP, which is a network of PLHIV in Indonesia. He's a trained in medicine, and they have been involved in SRHR movement for several years. So let's all welcome our 4 community speakers who will be sharing their experiences in their CLM program. So I think all of them have they turned on their videos, our 4 speakers here? Perfect. So let's start this moderated discussion and sharing of experiences. We have a good 1.5 hours to remind participants that we are opening a space for people to share and to ask questions as well. But let me start off the discussion with asking each of the speakers to share a brief background, a short summary of what you're doing in your CLM program. What is it about? How long has it been running? What are you doing? What are you monitoring exactly? And how you as a community organization is leading the process of CLM. So maybe we should start first with Bhutan. Can I ask Wangda Dorji to speak in behalf of Laksam? Wangda? Is Wangda here?
Yes,
Yes.
Thank you so much. Thank you so much for inviting Bhutan as part of this very important program. So let me begin by mentioning that Bhutan actually began before 2019. Bhutan didn't have any idea about the community-led monitoring. So basically, community-led monitoring, so-called as of now, so actually began in Bhutan through the Global Fund Regional Grant, to which AFO is the principal recipient, and then Save the Children country office is the sub-recipient, and the key affected population in Bhutan are the implementing partners of the project. So, community-led monitoring actually began, through the Global Fund Regional Grant. Before that, the community didn't have any idea of the community-led monitoring. So back then, initially when we began, it was not called as a community-led monitoring, but it was called as a guide to implementing community-based monitoring. It was called as a guide to implementing community-based monitoring. So later on, what happened was that the community themselves actually advocated to the partners such as Ministry of Health and the sub-recipient that it need to be the community-led monitoring. So during that time, there was actually 3 frameworks under the guide for the implementation of community-based monitoring. So basically, number 1 was using the community scorecard. And then second was to community feedback and then response mechanism system, and then key population perception survey. So that's how we began. And later on, the community, firstly, when we began, it was APCASO, Selvin was the one actually who came out with this guideline and this toolkit, and later on through the AFO and through the sub-recipient Save the Children, it was changed to community-led monitoring. And since then we have been actually carrying out the community-led monitoring for 3 times. Once in 2019, then in 2021, and then in 2022. And it came up with a very amazing result, whereby we can actually advocate to the government for desired change in terms of availability, accessibility, and then quality of services. So basically, when it was branded to community-led monitoring, then it was the framework used was AAAQ, that is to assess and then monitor the availability, the accessibility, and then the quality of services, including stigma and discrimination faced by the people living with HIV when seeking the services. So this, community-led monitoring tool was used in the second phase. And then later on, there was, lots of consultation between the, Ministry of Health, the sub-recipient, and the key affected populations in the country. So, basically the programs, the training workshops and all were conducted jointly. So later on, the community-led monitoring, was actually branded, and then, it was carried out among the people living with HIV in the country. So basically,
Sorry to interrupt you. Wangda, are you able to turn on your video? Is it okay for you? Sorry for that.
yeah, sure.
Okay, thank you.
Perfect.
Okay. So yeah, so basically, it was branded to community-led monitoring, and then lots of capacity building was done in terms of, building the capacity of the enumerators in terms of, going to the ground and then, collecting the informations and all, then, how to, record the data and then, analyze the data and then, produce it in a report form, including the, position paper, developing the position paper on the specific, key, data. So, that's how, the community-led monitoring actually began in Bhutan, starting from 2019. And then now, since I think some weeks back, we actually conducted the third community-led monitoring. Yeah. Thank you so much.
Thanks, Wangda. That's a good overview of how CLM programs started. And in many CLM programs around the world, it's usually initially supported by an external donor. But definitely what we need to highlight is how community-based organizations are involved at the start of those processes at the same time. But to give more enlightenment to how the Bhutan CLM program is going, we'll probably ask Tenzin to share also, because this is a collaborative CLM program in what is happening in Bhutan. So from the perspective of Laksam, we'll proceed to the perspective of Pride Bhutan. So Tenzin, would you like to share additional information from what has Wangda already explained?
So I think, am I audible? Because
Yes.
Yes. So I think Sarwangda actually has spoken and actually presented everything in a nutshell. So actually, there are some things that I really needed to add. In the beginning, I think it was just Laksam and Pride Bhutan implementing CLM here in the country. But then in the second round of CLM, I think we had Chitin Fendi Association. It's an organization for drug and alcohol users in the country. So they also joined us, and then actually we were jointly implementing these projects. The one other thing that Bhutan did was that we had consultation with the national programs and Ministry of Health at the beginning of from the beginning. So that's why I think when we communicated our findings and results, actually they were responsive enough, not so much, but I doubt that they can do everything that we recommend. But the good thing that we saw after the first round of CLM was that they actually extended the opening hours for standalone HIV service center, health information and service center. So before they used to open from 9 to 3. Because of our recommendation in the first CLM, they actually extended around 2 hours. So now the opening hours for the HIST is from 9 to 5 p.m. So the thing is, I think one of the challenges, if you look at it, is that we do not have, like CLM, like in other countries, is not a regular process. It is carried out as a time-bound project, whereby it's almost like you are carrying a survey. So most of the CLM that we have carried out till now has been done in a survey format, whereby we have this many days, you collect data, these are your targets. So then you have inclusion criteria from each population. Our inclusion criteria for last 3 CLMs were that they should be above 18 or 18 years of age, then they should have accessed health services in past 12 months. That was the time that was the thing we did. And when you look at the CLM, we had I think Sarwanda talked about AAAQ, but generally what we are monitoring here in Bhutan is that HIV services is one key factors. ARV stockouts, then we have condom and lubricants, which talks about preventive packages. Then we have also TB services. The additional that we have seen here as the country and as we went on, and we also adopted monitoring, rehabilitation and counseling services here in Bhutan. Because we began to involve CPA, Citizen Friendly Association, in our CLM group. So then we also added monitoring the rehabilitation and counseling services. And one other thing that we have also added is monitoring the general health services. Because if you look at here, if you look at Bhutan, when you assess or monitor the health services in past 12 months, the people who are seeking HIV services, ARV, let's say HIV related services, TB related services, it's very low. For an example, in 2020, I think it was the second round of CLM, we saw most of the members, they went to health center to seek COVID services. So that became our primary focus. That is how we adopted in Bhutan. I think that's it. That's it on my side.
Thanks so much, Tenzin. That's very useful information that I got from the CLM program in Bhutan. And I think it's very important to note how services or what you are monitoring expands through time. But one key issue that maybe we can deep dive later on is the issue of it being seen as a one-time project instead of a routine, systematic way, which we all advocate for a fully funded CLM program. So later on, we'll come back to that to try to uncover what's the issue behind not it becoming really a CLM program instead of a CLM project per se. So let's proceed first to the next speaker in Nepal. So Sarah, in Nepal, how does the CLM program work and how is it as collaborative as our colleagues in Bhutan, or what is the specific services that you're monitoring and how long has it been running? Sarah?
Hi everyone, Namaste. I'm Sarah Thapa Magar and I'm from National Federation of Women Living with HIV and AIDS. And it's so nice to see myself in this camera after like so many long time I'm back. So, and I'm so happy there's so many Nepali people who have joined. And I think if I miss anything, they're like my whole team is back for me. So yeah, thank you for that. So actually in Nepal, it's very collaborative and also inclusive in terms of community member and also in terms of stakeholder and government people. So actually what we feel and what we believe is that until and unless government don't take ownership, the sustainability of program is always questionable. So that's why in our CLM, all program it's supported by our government. So that is the good part of Nepal. And we recently finished a pilot project here in Nepal, and we collected data, and after all the results, now we are part of advocacy, also doing collaboration with our government people, stakeholder, and community member. So as I said, we have just finished the pilot project. We have done monitoring in HIV services for PLHIV and other KPs, including in different services. So actually we have a national CLM tax team in Nepal. So that is especially in the central level, including of stakeholder like government people and also community members and donors. So actually what we had this issue is in Nepal, there are so many community people and very actively working in HIV services. What we feel that everyone cannot be in the steering team, like CLM tax team. So we all sit together and decided who will be representing in the CLM tax team. So we came up with the 3 representatives. What we do is whatever the discussion happens in the meeting, we go back to our community. We ask we share what we discuss and what is the suggestion from the community. So that is how we are channelizing with other community who are not representing in the CLM tax team. So exactly same we are doing in district level. So right now we are implementing CLM projects in 14 districts. So we have 77 districts, but right now we are only able to implement this work in 14 districts. So we also have local CLM tax team, including of all the government, and we have received a very good support from our government people to sustain this work. So that is the thing from our side. Like also we have data collectors and people who are working in this CLM work. They all are from our community member. What we are doing is firstly in Nepal, the community-led monitoring is like a new term, but that is really not new term because we were doing community-based monitoring. Our community people were always, continuously working on to see how it's going around and in terms of what is the issue, how we can sort out. But that was a community-based thing. But now we are formally in community-led monitoring. So that is what we are doing. So in Nepal, like we have donor, the project is funded by Global Fund and USAID, but that managed by UNAIDS. So we have only one work plan, one agenda. So that's very good. Like we have very collaborative and inclusive from our government and our community people and also from donors. So it's very supportive and it's smoothly running in Nepal. So that's the update from my side. Thank you.
Thanks, Sarah. That was a very quick like bullet points on how the CLM program in Nepal has actually evolved. And in many countries, that is definitely true how they started doing community-based monitoring. People and organizations have transitioned it to make sure that it's community-led. That's why it transitioned to CLM. And you highlighted also the importance of how you coordinate these processes through a task force, like a CLM task force. So thanks for sharing that. And from one task force to another task force, which I know is happening also in Indonesia, I would like to ask Brian from JIP to share their experience as well, how it started and how it actually transitioned as well to having a task force. Because I know that the program in Indonesia has started way back even in 2018, and it's a bit more established, if I may say, in a maturities of CLM program. Brian?
Thank you. So as you mentioned, actually, even though perhaps the term CLM is not so old, but the principles, the steps from data collection and then leveraging said data for advocacy is something that we've actually done for quite a while in Indonesia, because we believe in approaching stakeholders with those data. But as the term CLM comes up and emerged in the regional and the national level is where we started using the term CLM itself. But our experience allowed us to mature, as you called it, and really learn. And when we started using CLM in 2021, we actually have now a few initiatives that also work together. For example, we have a USAID-funded CLM called Advocate for Health, which works in 3 provinces or 13 districts around our capital, focusing on the improvement of health service delivery. So through community scorecard, through trainings, development of policy briefs, we're really working with other partners such as clinical logistics, other CSOs and communities to push for a more person-centered care. But we also have other initiatives, as I mentioned. For example, the Advocate for Health started in 2021. Last year, we had a more wider scale of CLM called Joint CLM. It was carried out by JIP and 6 other key population national networks, actually, from the women living with HIV, the sex worker collective, and then the young key population, people who use drugs, and the transgender community and the MSM and trans women community, as well as us. We collected data first throughout the whole year, actually, even. And we were able to conduct both national and district level policy dialogues, leveraging on the data that we were able to collect. We also actually not only work in HIV, but after all, people living with HIV also face other issues. For example, in tuberculosis, JIP implements CLM in the field of tuberculosis through the Stop TB Partnership global funding through CFCS, or the Challenge Facility for Civil Society grant. We also work actually with the other national networks, namely the Women Living with HIV Network, and then the People Who Use Drugs Network, and the MSM and the Trans Women Network. And we also work with the other partners from CFCS, such as the TB community and the POP TB Indonesia. My apologies. Where we leverage actually a tool that has been used globally, the One Impact TB. If you've ever heard of it, I'm sure, is the Stop TB partnership tool, enabling people with TB to connect with peers, to also access TB and report any issues that may arise during their treatment. And as well with other CLM implementers, whether it be from Advocate for Health, from the Joint CLM, from the TB and other initiatives, we actually, as you mentioned, create a task force, officially called CLM INA task force. INA stands for Indonesia. And so we work together to compile the data that we have collected. After all, it's from different districts, from different issues, but all serving the same end goal on how we can be involved in the national program to give community input. And we leverage on that data, both at the national level and even at the district level. I think for your first question, that would be all for me. Thank you.
Thanks, Brian, for sharing the immense work that has been done already in Indonesia. And as we can see, a lot of our donor technical agencies, Global Fund, USAID, UNAIDS, has been supportive of these processes. And as we know, these are external donors. These are people who has technical support that is being provided. So I want to go back to a question back to each one of you about, you accept funding for CLM program, and they also support you in designing and developing your program. So how do you ensure as an organization that your organization remains to lead and own the processes? Where do you draw the line between the collaboration with your donors and technical agencies, and as an organization to ensure that it remains community owned and community led right from the start? Maybe we can ask first, going back to Wangda for Bhutan, then followed by Tenzin, then Sarah and Brian. Wangda?
Can you please repeat your question once, please?
Yeah, how do you ensure that even though you are receiving support, external funding for CLM program, you're receiving technical assistance support as well, how do you ensure that the process remains to be community-led and community-owned? And where do you draw the line to make sure that it remains to be led by your organization?
Yeah. Oh, thank you so much. I think regarding the processes, I think it is very important that we coordinate and collaborate with, our very potential partners, such as Ministry of Health and other, potential partner. It is very important to collaborate, but when it comes to, owning, as a community-led, having that ownership, I think community will have that ownership, because although we, develop and, we, carry out all these processes together, but then, when it comes to the, questionnaires, right? When it comes to the questionnaires, then it is, the community actually, decides what questions needed to be administered to our, beneficiaries. Because this, I think, have to be owned, I think equally by the government and by the community, so that, we have, that push, and then, and then pull back, right? So, so I feel that, community, led monitoring, I think community will definitely, by sharing the experiences with Bhutan, community will definitely have that ownership over this, this program. And at the same time, we will also have that, equal partnership with the government, because at the end of the day, the change has to come from the government, right? We need to collect all those information, all these data, and then present it to the government. The most relevant government ministry is the Ministry of Health. So, by working in partnership, while we present this, we want the ministry, we want our partners to take action. Supposing if there is our communities are facing stigma and discrimination while assessing the services, then the ministry should take the action in terms of sensitizing, if not educating, if not providing them refresher trainings, making them understand on the SOGSC, about the drug and alcohol, as to building the capacity and their potentiality as to how they can deal with these people in a most efficient and in a most human manner, so that we do not drive away these people from the services, right? So basically, the community led monitoring is to improve the services in partnership with our beneficiaries and in partnership, strong partnership with the government. So basically, what I would say is that, we need to have that equal partnership, because in the end, one day, the global fund might phase out, right? So during that time, the government should take the ownership in terms of, especially, providing us the, assistance and also, resources, including, money to carry out this program, so that the, gains made, over a period of time is not lost. So after the donors actually phase away. So I think, for Bhutan, so as we take the processes, we want the government to take the equal partnership, to take the equal ownership, so that, in the future, we work through the, government mechanism of maybe social contracting, right? So which is one of the, agenda through our regional grant, a Global Fund regional grant, building the capacity of the communities, accrediting them, certifying them, and then making government to, hire them, contracting them the work that government cannot actually reach out or cannot perform in a most efficient manner. So this is my personal stand on the community-led monitoring ownership. Thank you so much.
Thanks so much for that, Wangda. Definitely, you keep on reminding us the equal partnership with other stakeholders, especially the government, and making them accountable and actually co-creating solutions and action points that is based on the CLM data. So I'll just go back to Tenzin as well, maybe to add a few more experiences being community-led. And I want to add an additional question to Tenzin. How is it working with other key population organizations in making sure that the CLM program works together seamlessly in Bhutan?
I believe when you look at Bhutan, I think the three KPU organization, I think we have been a united voice. I think that is one important thing that we really need to understand and come together and push as a one voice. That has been happening here in Bhutan, and I think that is why that is one of the reasons that the CLM is going really well here in Bhutan. And one other thing, I think since now, if you look at globally, regionally, the funds are drying up, especially when you look at the global funds, and we are really worried. But I think when you look, if you plan smartly, I think we can take this forward, because lots of capacity building has been done in regards to CLM. When you look at APCOM has done so many webinars, trainings. When you look at CLM implementation in Bhutan, we had so many capacity buildings even when it comes to protocol development. I mean, like cleaning the data, analyzing data, and I mean, like generating reports. So that has been done, and I think KPOs in Bhutan I think they are now ready to take this forward. But since we are CLM is a time-bound project, they have budgets to spend, so we usually end up having a national technical consultant to help us with the development of. But the work plan and everything is done by the KPOs. Even when it comes to training, I think we do collaborate, and then even the facilitation happens through the, I mean, like key population organization that has been happening. One thing that I really needed to remind was on the collaboration when it comes to Ministry of Health. Like I said, we have been involved in Ministry of Health from very beginning. What I really wanted to tell was you cannot expect them, you do everything and then you communicate, okay, this we found out these are the issues from the CLM. You will, I think you will, I mean, catch them off guard, and they might not be, I mean, like willing to participate because they might say like, you have not done any consultation with us. Now you are coming with the results and reports. How are we supposed to take it? So working with the governments is tricky. And when you look at the CLM, you are monitoring all those aspects of health services, HIV services, and it becomes kind of pointing fingers to them. So they are quite, I mean, like not receptive if you don't consult them for from the beginning. I think that is one key, I mean, that is one good thing that Bhutan was able to do here.
Thanks, Tenzin. Definitely in setting up and starting up CLM programs, it's important to already get support and buy-in of ministries of health to avoid seeing community-led monitoring data being seen as a criticism to public health services. And definitely that is important. So I'll give the floor now to Sarah to share experiences in Nepal to how to make sure that the process in CLM in Nepal remains to be community-owned and community-led.
Okay, before that, I would like to thank APCOM and all the regional network because since last year, APCOM is organizing all the webinar and telling us about the CLM, why it's very important for the community to be involved and especially the ownership of the community people. So because of that, we are here, we are learning, we are still learning and doing all the stuff in Nepal. So even if it's not CLM or if it's CLM, the community always stand together and we have really good coordination with each other. And if we feel like it is not benefiting the community, even though there's lots of money, lots of everything, we just drop it out. So we have that kind of coordination and collaboration within our community people. So first thing, we had these issues with the government people that they had this kind of kind of thoughts that community-led monitoring is all about the asking question about their services, but it took a lot of time to convince them it's not about the questioning their services and their work, but it's about the we supporting them for the quality services. It's about us for us. So it took a lot of time. And talking about the representation of the community member, so we are represented in all levels, and also not only the representation, but also we have the meaningful decision making. We are also in the part of meaningful decision making, I can say, not only in the national level, but also in the local level. That is why we are doing this good work with our local government and also with the stakeholder. And if there is anything that is need to be done, it's always community. If there is no community representation, the work will not go forward. And also we take a lot of time because we have different people with the different language barriers, and we take that as in we always look everything is for the community people first. So that is how we are doing. And also the coordination and collaboration with not only with the people living with HIV networks, but also with the different community people like key affected population. Right now in Nepal, CLM is implemented by Spursa Nepal, NFWLHA, which is my organization, and NAPN Plus, which is all community-led organization, and also in the 14th district that we are doing. And we are also helping our community member to understand that the community always come first, and also they should take the ownership, because all the technical stuff or all the task group is run by the our community people, that we are also making them accountable for their issues, what they are raising for. So that is the thing from our side. And also we are taking a lot of time to make our people to understand that data ownership and also decision making, and also, you know, make accountable to our stakeholder and government. So I think in Nepal, our decision really matters in terms of funding, or, you know, deciding whatever the things. Even sometimes what happens is you are getting lots of money, and you sometimes you cannot express what you want. In Nepal, that is not the case. For example, if we want something, we say, okay, this is not the thing that we need. This is the what we need as for our community. We have this kind of, you know, decision making and representation, and also collaboration and coordination with other stakeholders. So that is from Nepal.
Thanks, Sarah. Every time you speak, I feel like I'm trying to catch my breath as well.
Sorry.
So try to relax. We do have enough time to expound on all of those experiences as well. And you mentioned about your experience in working with other key stakeholders right from the start. And yes, it always takes time to convince and get buy-in for the people that you want to involve in the project as well. So we still have a few minutes to discuss this panel discussion, and later on we will be opening the floor to other people to ask our speaker questions or even share your experiences. So let's go first to JIP, to Brian, also to share to us the experience in the task force and making sure how do they collaborate. These are 6 different key population organizations, and also how to ensure that it remains to be community-led with all those different funders and technical agencies supporting JIP. Brian?
Thank you. So as part of the community ourselves, we actually are able to meaningfully engage from the beginning, from the design. And that, I think, is really important to be able to see, as has been mentioned, that the stakeholders, the governments are partners with us. We ourselves and the diversity of the community are also equals. And so working together, we designed the program in such a way that all of us can be meaningfully involved, including those perhaps that we see may not be fully able to, but we always try to put in, okay, so how can you be involved, or even design capacity buildings, trainings. And I think that's a really key part of it. After all, different communities, even different individuals have their own capacities, but at the end of the day, CLM is community-led. And so they should also be able to be involved. And so those kind of trainings are really important to be able to allow them to be meaningfully involved. I also want to highlight as well, it's not just from design and even the implementation, but also even in evaluation, whether it be at the end or periodic. We can sometimes get lost during implementation. I mean, I know as every day I look at data, I clean, I verify, but like, I always have to make sure, is this really what the community wants? And so just periodically every quarter, for example, discuss with the end beneficiaries, discuss with the communities, is this going as we had hoped? Is this going well? And so it's important to keep on track to ensure that the community really feels that, okay, this is community-led monitoring. This is, we own this. We can take part in it. Our voices are actually meaningfully heard. I think that's the only thing I can add from this. Thank you.
Thanks, Brian. Definitely, it reinforces the idea of the whole CLM cycle, not only in design phase, but definitely a step forward to really be involved up to data analysis, utilization. And those are, in most cases, initially starts with an external consultant helping us, but eventually those knowledge should be embedded within the communities for them to do it themselves, for greater involvement of communities as well. We still have a few minutes and we are parking some questions on the side. And I encourage some of the participants to also share your thoughts or questions or sharings. But I want to add just maybe a few more questions back to the speakers. I have a question specifically for Bhutan. my question in Bhutan is, what exactly did you do to get government support in your CLM project? Are there specific steps that you need to do, or any advice for our participants on how they can make sure that the government will be involved in this? And either one of Wangda or Tenzin maybe can contribute to that question. Maybe Wangda?
So in terms of ensuring
Tenzin,
collaboration
sorry.
with the government, I think we kind of actually forced national program to be a part of the CLM. Actually, since Wangda sir has stated that the projects here, especially when it comes to HIV, LGBT, and female sex workers, it is done through Global Fund. The majority of the fundings come from Global Fund. And then we have regional grant with Save the Children Bhutan as the country PR. And then we have GIVTM projects where the NECP is the country PR. So it kind of, since we were already engaged in lots of, consultation, and then we work together in this both regional and national grant. I think that's how we actually slowly began to also bring them. I think when you look at the whole CLM planning and everything and consultation meeting, I think Save the Children actually did a very good job bringing in a national HIV/AIDS control program to the table to discuss this. And I think it was also quite understanding from National HIV/AIDS Control Program to be able to be very open about this. So I think that's how it's not much of what we did. It's kind of like I said, we kind of forced them to be our stakeholders in CLM.
Thanks, Tenzin. Maybe, yeah, it's true. Sometimes you need to a bit more convincing and I need a little bit of pushing to get the CLM program up and running, but eventually it takes time for them to recognize the value of what CLM data brings in. And maybe for Wangda, I do have a question coming from the chat about, let me read it to you. Were the community of PLHIV or the PLHIV community, are they well capacitated in terms of being meaningfully involved in processes prior to CLM implementation in Bhutan?
Oh, thank you so much. I think it is, quite challenging to, involve all the people living with HIV in the country. So firstly, most of the people living with HIV who can actually read and write in English, are in the jobs. And, currently we have around 257 HIV positive members. And then, I think 38.8% of them have, never gone to school in their lifetime. So, it's quite difficult when we do this community-led monitoring, especially, when it comes to enumeration training and all, it's not really much of a problem because they can, we can, actually, inform them and then educate them on how to, conduct a community-led monitoring. But the problem is with the technical part when it comes to like entering the data into the software and then cleaning the data, analyzing the data, and then producing the report. And not only producing the report, but also coming up with a brief statement, position paper, and being able to put that report into a presentation and then turn it into a policy advocacy presentation. So that's sort of a capacity because of the fact that Bhutan is a very small country of around 700,000 population. So once you are out, then nearly everyone will know your HIV status. So that's why self-fear and self-stigma among the people living with HIV is very high. And those people who are with Haksam, as a member, as a beneficiaries, they come from a very disadvantaged family background, and then many of them are have never gone to school. So that is the biggest challenges we are facing. But then we are using our staffs who are HIV negative and are well educated to get trained on all this technical part. so that we keep it as an in-house capacity. So later on that we use this in-house capacity to build the capacity of our HIV positive members who are indeed, willing to come forward to be a part of the organization in terms of, carrying forward this community-led monitoring. So
Thanks.
yeah, that is the biggest challenges that we are going through.
Thanks, Wangda. You highlighted very important things about internal capacity building. That's why I think it's very important in most cases that other interventions aside from community-led monitoring, which are relevant to community system strengthening, are very important. There should be capacity building, there should be community-led advocacy, and there should be community engagement that is funded to support all these different community system strengthening process to strengthen your CLM program. And that's very important as well. So maybe I'll just ask a question to first GIP, to Brian. One question that was shared in here is that, what do you think are non-negotiables that could protect your community or your organization's ownership of the CLM program, and to make sure that external stakeholders or partners are not dictating you, the CLM task force, on what to do?
Well, thank you. From my own experience, oftentimes those donors and external partners, what they're doing is essentially, how do I say this? Sharpen. It's not so much as dictating. Of course, we have our own priorities. We're the ones in the community, but they're simply sharpening. And so it's essentially a process of negotiation where we need to look at A, but we also see B. So it's actually, the framing should be a win-win. Okay, we can look at perhaps both, or if the resources are not enough, what advocacy, right? And so, like, the most simplest example, if is an issue arise that the donor asks us to look at, but our resources are limited, to be honest. And so we look at, okay, we can try to integrate that issue into our own activities. We can try to look into it. It perhaps may not meet all of the standards. I mean, there's a lot of things that can be looked at, right? But we also agree actually that that issue is important. It's just that we have a lot of things on our plate right now as well. So it's just a matter of negotiation, and at the end of the day, again, from my own personal experience, they can actually work well with us. They can understand as long as we communicate clearly that, oh yes, that is an issue. We will look into it when we have the time. It's not, sometimes we say it's like stalling, but it's actually, well, with the limited resources, we can do this. And then they say, okay, and then we work together on that issue. I think that's all from me. Thank you.
Thanks, Brian. Very important point about it's a mutually beneficial process, and it's a collaboration between, and definitely it takes a lot of negotiation and discussion with your technical partners and agencies to make sure that this program works. And I like what you said about it's not dictating, it's about helping us, supporting us, sharpening it, using their technical knowledge to improve the services. So I would like to ask the similar question in the context of Nepal to Sarah. What do you say would be your non-negotiables to your funders, donors, to make sure that the process remains to be community-led and community-owned? What would be the non-negotiables for you?
Okay, so hello donors over here. So there are many things, as I said, for us, especially in Nepal, our community members always come first. We come first. If it is not benefiting our community, if it is not giving any security in terms of data and all this stuff, and if it's not related, if that is not benefiting in any way, then it's like non-negotiable from outside. Whatever the project it is, if our community member is not getting services on time, if it is not related with our community, sometimes the project is just like, they just have this money, and if they want to spend this money, so they just come up with this different thing. So if it is not benefiting our community in not good terms with our community, it's always non-negotiable for us in Nepal.
Thanks. Thanks, Zara. I think that really values the principles of why it should be community-led and community-owned, because it should serve what the communities is for. That's why you decide on what should be monitored and how data should be used and what changes should be made. Thanks for that. And a question for Tenzin, for Bhutan. Do you have any advice on how community organizations under an authoritarian regime can engage or negotiate with state agencies in order for CLM to proceed?
I believe that I'm the wrong person to answer this question, because Bhutan, it has been quite easy for Bhutan, but I think you can use lots of stakeholder and use their shoulder to fire the gun. Actually, if you have funders who are major, who usually funds the, I mean, like state, especially when it comes to health, I think you can use that platform, funders, and then other stakeholders such as UN agencies to actually negotiate on behalf of you. I think that can be one of the I mean, like ways you can engage when you are in such kind of situation.
Thanks, Tenzin. Maybe we can also ask other participants who are around in our chat, who maybe could share if they have experience in working in a country with an authoritarian regime, on how CLM programs has been pushed or advocated for in that case. And maybe a follow-up question for Wangda in Bhutan. Given that the program was supported as sort of a one-time project so far under SKPA, what has been the plans or efforts to push for a more institutionalized CLM program, and can be done in a more routine, annual, quarterly basis, to ensure that the efforts from the initial pilot continues through the years as well? Has there been any progress or discussions or efforts on what needs to be done for it to be really more of a institutionalized CLM program? On that?
I think for Bhutan, in joint collaboration and coordination with our other key affected populations such as Pride Bhutan, Red Cross Network, and then CPA. So in order to institutionalize, the community-led monitoring in the long run, so one of our, what you call the process that we are taking is through the Global Fund Regional Grant. That is, actually, the sub-recipient is Save the Children Bhutan. So what we are doing is that currently we are actually developing a, training model for this key affected population, whereby the university, Kesagyapo University of Bhutan, will train the people living with HIV and the key affected population based on the model, and then exam will be conducted after that. So those who pass the exam, then they will be awarded with the certification and accreditations. So once they get certified and accredited, then they can be socially contracted. Especially the ministry can contract them. So on the other side, one of the processes that we are also through the sub-recipient gathering all the informations on the financial gap related to HIV response. So one of the study carried out in the country was also the HIV allocative efficiency analysis, which indicates that the HIV funding for the HIV needs to be quadrupled. Otherwise, ending AIDS by 2030 will be quite difficult for Bhutan. So one of the steps that we are taking is that after the accreditation and certifications, then the National AIDS Control Program, which means the Ministry of Health take that, ownership in terms of, continuing this program in joint collaboration and coordination with the key affected population. So this is one step going on. And last time the presentation was made at the CCM by the Save the Children and the consultant. And then, the director of the public health, and other, technical partners were there, including Ministry of Finance, and then from people from the WASH National Happiness, we are there. And, initially it was, they were quite resistant, but then, when they were informed and then explained well, then they understood, actually why it is so important, that social contracting need to be done, because, we cannot leave, anyone behind. So in order to make sure that no one is left behind, they came to know and they accepted, acknowledged that this community people need to be engaged. And they are trying to find various, means and ways in terms of, actually, putting a budget line in the Ministry of Health, so that, this can be funded directly through the, national 5-year plan. So those sort of a negotiation is going on when it comes to institutionalizing the community-led monitoring in the country. So on the other side, what we are also trying to advocate to the Ministry of Health and also to the National AIDS Control Program is to recognize the community-led monitoring, as the national, intervention, and then recognized it through the Health Research and Ethical Board, to get it approved through the Health, Research and Ethical Board, so that the community-led monitoring data that we produce, the report that will come out, becomes authentic, and then we can also use in the larger platforms for seeking a desired change in terms of improving health service delivery to our key affected population.
Thanks, Wanda. I think 2 points coming from what you shared definitely is the efforts towards sustainability of CLM programs is really towards domestic financing, social contracting of CLOs and CBOs to be able to do this work, important work. And as well, how do we increase credibility and authenticity of data, and definitely partnership with research institutions, getting IRB or ethical approval is an approach being taken by other countries to make sure that their CLM data gives more credibility and soundness to it for ministries or governments to believe in. And I want to ask that similar question as well in Indonesia and Nepal. What is the approach currently in Indonesia or Nepal towards institutionalizing? Because I know that this is currently still being funded by your external partners. What is the approach and discussions now towards ensuring that communities remain to lead these processes, but institutionalized and well-funded within domestic resources in your country? Maybe I'll go with Sarah first.
So I just saw a question from Abhinavi as well. So like the sustainability part is always a big question, not only for the CLM, for other projects as well. In Nepal, we have from our community members, we have really good coordination and collaboration with our local governments. And especially we have really good one of the best example right now is that in province number 2, where we are implementing this project, our local government is also offering spaces. And so this is just a starting. So if we want to that doesn't sustain not just only with the donor projects, the only thing is that the government should take ownership, and we need to convince our government that this is very important. Sorry, this is very important for us and for our community member. So that is why we have involved our local government, and especially in national and also in local, that government people should take the lead. But the issue with us in Nepal is that the political instability is here. Like it's like we inform this new person and it's like final, and also then new person comes and we also have to start from zero. Then this is the issue here. But still after having said all these things, our community member have really good coordination, and to sustain this and to go in a long run, the community should understand that this is important for them, and it is not a project based, it's an ongoing process for very long term, and I think the government should support this to be sustainable, this project, I think. Thank
Thanks,
you.
Sarah. I think your response already answers the question also on the chat about how communities takes leadership for CL implementation and importance that they need to understand what the data is for and how it is going to be used as well. So definitely you highlighted already how you are involved in the different processes, and you also answered the question about is sex workers involved in the CLM program. Yes, I think in all the 3 programs across Bhutan, Indonesia, and Nepal, sex workers are involved in the processes, even from the CLM team that is implementing the program. So I would like to ask Brian to answer the similar question I asked about institutionalization and sustainability, perhaps, of the CLM task force. And also, if maybe you can answer another question that was raised. Is there an issue, or are there issues related to integration of CLM projects through the task force, and how is the community or how is the organization managing this issues, probable issues in integration, right?
Okay, thank you. So when we talk about institutionalizing, one of the key things that could be done is actually about domestic financing regarding specifically social contracting. And there's actually an initiative that builds first upon the capacity of the community. So it's not just us building the capacity, for example, for data collection, but even in social contracting, right? On how to write proposals, etc. But how community is still meaningfully involved in these initiatives, so that even say without external funding, we could still be able to really push the community to want to implement this, right? But also that the government can take part, should even take part in supporting this initiative. And a second thing actually that regarding the question in the chat regarding the task force, any issues, as it's actually a cross-cutting platform that involves several CLM projects. Understandably, there's a lot of data, and also there's a lot of things that could be looked at, right? Whether it be specific HIV service or even outside of HIV service, but at the same time, we still have a shared understanding of what is important through our discussions, our dialogues. And so we can, and this is something that we actually are a bit proud of, that the task force has a, I guess you could say, minimum standard indicators, where and this also relates a little bit with sustainability, where even with relatively minimal funding, we can still look at these numbers, we can still look at these indicators, right? And so we are able to work together, all of these networks, and take ownership. And I think that's something that's really important, that we all agree, okay, this is what is important, and let's work on this. Thank you.
Thanks, Brian. I think you highlighted a very important point about setting minimum standards across all the different groups as well. And that's very important to create better understanding and collaboration and integration. That each key population have different specific interests, perhaps, and there's need to be something that brings them all together to make a CLM program as vast as this, or as expansive as this, to be more collaborative in that sense. And we do have still about 5 minutes to open questions from the field. If anyone from our participants are able to speak, or you want to share, if it's not a question, maybe an affirmation or a comment, or maybe sharing from your own experience in the country, aside from Indonesia, Nepal, and Bhutan, you feel free to share your experiences as well. Let's just give a few minutes while we run through the chat as well. I have a question on sustainability. Are there also efforts to integrate HIV-focused CLM to the other CLM models in other health concerns like family planning, mental health, and TB. So I know that Indonesia mentioned about having an HIV CLM and a TB CLM. How does it work? Do they collaborate together? Is it an integrated HIV TB CLM mechanism? Maybe you can share that, and maybe I'll ask the other speakers as well. Thanks for the question.
Thank you. So when in regards to TB, there is a specific project looking at it, allowing, for example, reports of any stigma and discrimination. But even in, well, the one that I personally hold, Advocates for Health, the US funded project, we actually look also at any other possible services that may be related. For example, if they feel that they need family planning services and whether or not they feel like they need hepatitis C testing and treatment. And this is a really key issue in the design, actually, and something that, again, I personally am proud of, that when we design the tools, we also look at other needs. It's not just looking at, oh yes, ARV services available, fees, but also looking at, as people living with HIV also have, you know, various needs. It's not just the medicine, it's family planning, it's whether it be hepatitis C treatment. And again, based on our design, we were able to accommodate that, even when we found, for example, that an end beneficiary reported that they were not able to get family planning services because they didn't fully understand about it. So we were able to design one of our routine webinars to ensure that information is provided, actually, to allow those who want family planning to know about it. And yes, thank you.
Thanks for that response, Brian. There was a follow-up question actually here about, are there CLM programs that works on AAHD and OI, which is basically opportunistic infection and advanced HIV disease?
Specific project for AHD, I'm not 100% sure I've heard of it. It's more integrated. For example, when we ask about what you need, and so some request, for example, CD4 testing to be covered because, for example, they know that their previous testing was actually relatively low, and so they'd like it to be regularly monitored. And so we leverage on the data for our advocacy. That will be actually an input for us to further expand possibly, but we will of course see our available resources. I'm not 100% sure as well, but I'm sorry if there's any more. I'll try to make sure to share.
Thanks for that clarification as well. And definitely most CLM programs usually expands based on the needs and the context of the country on what really needs to be monitored. And definitely that could be a potential discussion for them in their improvements of their program. I would like to also ask maybe Sarah and our colleagues from Bhutan about that question about, is your current CLM program being expanded to also cover other CLM models? I heard from Bhutan about they started asking about general health services already in their CLM program, not just for HIV. So maybe we can ask Sarah first in Nepal if there are discussions on other integration in other CLM models.
So we have integrated, but not very specific. For example, right now we are focusing on HIV prevention, treatment, and retention, but that is not limited with this only. Like we are also linking with human rights, hormonal therapy, STI, and OI, and other things. But we are not, not like Indonesia that we are into other things as well. Right now, we just want to cover these things, and maybe this could be suggestion for us to, move into another thing as well. So we will take this as a suggestion. Thank you.
Thanks, Sarah. How about our colleague from Bhutan who would like to expand on that question? Wangda or Tenzin? Maybe Tenzin.
I think when it comes to expansion, I think we are finding it, first of all, difficult to regularize it, to make it a regular project and ongoing project. But the plan has been already, plans are already in pipeline. I think Sir Wangda actually covered most of it. But one other thing that we are doing, especially when it comes to our level in Pride Bhutan, till we are able to make it as a regular project. So from next year, I think we have already integrated into our outreach and networking services, especially the community mobilization activities. So the integration has already happened, and I think after June, I think we will be able to. I think it is kind of pilot in our part. That is what we are trying to do. The other thing that what we are also pushing for in the national program is that to integrate CLM into HMIs or HMIs, Health Information Management System, that is being used by the Ministry of Health. So that is what is happening right now in Bhutan.
Thanks, Tenzin. I'm just mindful of time that we do have 30 minutes left. We do have final sessions and opportunities for our speakers to respond to your questions and any other final messages. So that, if I may say, 1.5 hours has been very fruitful discussion, a lot of sharings, a lot of suggestions and recommendations. And there's a lot of key asks that is already being mentioned by our community leaders in here based on their experience. So I just want to show a Menti for our participants to fill up. There's just one question that we want to ask you. Can we show the Menti code? Okay, please go to menti.com. You can enter the code or you can scan the QR code. So we only have one question for you to respond to share. We are already very glad for your questions on the chat box. I know some of you might not want to speak during, but I see the activeness in our chat group. So if you can enter menti.com, and there's just one question there. Can we show the question? So the question is basically in the Menti, to provide a word or a phrase or a short answer, what do you think are your key asks for ensuring a community-led and community-owned CLM project from the setup to implementation phase? So again, what do you think should the communities demand, or what are your key asks from the moment you are still setting up or designing a CLM project? So you can answer multiple responses to these questions, and while the participants are sharing their experiences or their responses to this Menti question, I will give the floor to each of the final speakers to give their key takeaways or their own key asks in terms of their CLM programs. So to the speakers, I would just like to ask you as well, what do you think are your key asks in terms of ensuring that your CLM program remains to be community-led and community-owned? So maybe we can start with Wangda. What are your key asks in ensuring that your CLM program remains to be community-owned and community-led? So key messages to our participants as well.
The key messages that I would like to give up in order for the community-led monitoring to remain as the community owned. So as I have mentioned, already mentioned that we need to really collaborate with Ministry of Health, and it is not just the community ownership. I think if the community alone take the ownership, then at the end of the day, as I've mentioned, this report needs to be presented to the Ministry of Health, and they are the one who we have to take the action. So for me, this has to be, the equal partnership and then equal ownership. But whereas it also becomes the ownership and then the, the what you call obligation of the government to fund this, program, and in order to and then further strengthen this program. I think this is the responsibility of the government. And I think, this push need to be continued, especially for Bhutan. We will keep on, advocating to the government that they have to take the responsibility, while the community-led monitoring, becomes the ownership of the community, but at the same time, the government needed to fund, so that, community can take the full, ownership of the community-led monitoring.
Thanks so much, Wanda, for that message. And let's proceed, maybe Tenzin, to add on to that, especially for CLM program in Bhutan.
So I think when it comes to CLM, I think one crucial thing that we are missing right now is the demand generation for CLM. I've been saying this for a very long time, because many of the communities does not know what is CLM, that they do not know that such kind of mechanism exists in the country whereby they can actually communicate their issues when they access health services. That is not there. I think this is one of the biggest reason why we have been conducting CLM as a time-bound project. I think we really need to put in more resources when it comes to demand generation, making people aware of the such kind of mechanism. I think that is where I think we should look at. And I think one other thing is, I think we are, especially in Bhutan, I am 200% sure that we are ready. Actually, we can take it up way better than what the national consultants are doing, what our PRs are doing. I think we can do it better. I think they really need to trust us when it comes to giving full ownership when it comes to the CLM.
Sorry. Thanks, Tenzin, and thanks, Wangda. I'm really very hopeful because you already started a good CLM project, and definitely you have great ideas and how to expand it, and you have great ownership and leadership leading this process. And we fully support how the CLM program can be more institutionalized and can be done in a more routine manner as part of Bhutan's monitoring system in case. So thanks both for your presence in here and sharing the experience in Bhutan. I would like to give now the floor to Sarah to share your final key takeaways and messages as well.
Okay, so I can connect with Tenzing, and one of the things that I want to share is that actually our community people really don't know about the quality services. When we actually went in our field and asked for the data collection, actually our community members don't know about what is the services they should receive and what they are receiving. They're all when we ask any question, they are like, okay, we are getting this, that is also okay. When they are not getting this, that is also okay. So actually the main issue with our community member is that still they don't know about what the quality service is, like what is the services that they should receive: dignity, respect, confidentiality, accessibility, affordability. They don't know about. They just are happy whatever they are getting. So that is the one big issue what we faced here in Nepal, and I think everyone should work on building the capacity of our community members as well. So that is the thing. And another thing is the ownership of community. If the community-led organization or community people are not being able to take that ownership, I will request our stakeholder to build up that capacity of those organizations and those people. So actually that will be a community-led monitoring. So that's from my side. Thank you.
Thanks, Sarah. And I'm sure the program in Nepal have more opportunities and platforms for it to be further expanded, because you have already a good foundation of your CLM program and engagement, and your understanding on how and what is the value of CLM remains there. And definitely I look forward to seeing a more improved and expanded CLM program in Nepal as well. Thank you. Thanks for your presence here as well. And last but not the least, of course, while he is answering the question on the One Impact tool, Brian, for your final key asked messages as well to ensure it remains to be a community-led and community-owned process.
I think the thing that I've highlighted as well is the capacity of the community, and because I believe that when we also build on the capacity, we also generate, well, it was previously mentioned about demand generation, but also the realization that, oh, this is our right to be involved, right? So when we do that, we can allow the community to be more aware that, okay, there's this space that we can use, that we can take, that we can discuss with relevant stakeholders. But at the same time, when we said equal partnership, that means it's not just community, but also government, their commitment to, for example, as I previously mentioned about domestic financing or any other perhaps possible mechanism. So when we try to ensure community ownership of CLM, we really ensure that this partnership really runs and it's there. I think that's the only thing I can add. Thank you.
Thanks, Brian. And that would be a fitting summarization to remind us that CLM is an accountability mechanism. It making sure that government and decision makers uphold to their commitments to providing a key of services, but also involving them in co-creating those solutions. It's not a criticism to them, but it's a method and a tool and a platform for you to collaborate and better engage to develop solutions to improve health services. And I think this 1 hour, 40 minutes discussion has been very enriching and very enlightening for our participants to know the experiences of countries. And we really hope that the knowledge that you gain in here will be able to be used for countries if you are still starting up or you're still at the design phase of your own CLM programs. May I ask the speakers to write their email address in the chat if the other participants might want to contact them. And let's all give our speakers a virtual clap to their fantastic sharing as well, which are very informative and it brings me to the ground. Being now with the Global Fund as a donor perspective, I always ensure that I go back to where I came from and to ensure that I bring voices of our communities to better make donors understand the importance of community-led responses and CLOs and CBOs. And that's what I will be committing to do in my current role coming from this side. And going back to the mentee question, I think many of you have responded to your key asks. And with that, I'll give the floor to Harry to synthesize what we see in the mentee in terms of what you have shared in your KS as well. So I would like to thank you as well, our speakers and our participants for this session today.
All right, thank you, Rain. So on behalf of Seven Alliance, I would like to thank you, all of you, for coming on today's webinars. We had very interesting and productive meeting. Thanks to all of you who actively participate in the discussion. By way of the reflection of our discussion on mentee exercise have highlighted the tactics, strategy, or approaches to ensure that CLM is community-owned and led. Getting the buy-ins and support of government and duty barriers in order for CLM to proceed. At the end of the day, it's about improving HIV services. Non-negotiable are when CLM project is not benefiting community. Communities should decide not to do it. In terms of sustainability, domestic financing and increased credibility of CLM work through partnership with research institutes that are allies of the community. I also want to highlight some quote that I really like. I really have enjoying reading it. It's from John F. Kennedy. He said, "Leadership and learning indispensable to each other." I hope today's webinar is able to provide, or at least to show you, that there is a leadership in you. And top of that, we also learn from other countries on CLM through today's webinar and advocacy and cross-learning. And it's been reiterated from yesterday webinars and today's webinar that, global strategy really emphasizing on the community at the center. So we should be proud that we have to make it ownership of our own CLM, because CLM is the way of global strategy try to showing it that community really at front and really at the center. So from the community, by the community, and for the communities. So can I go back to the screen and then see everybody switch on the camera? Are you already opened the camera? Okay, so does anyone know how the Persian snap? Okay, so now we come almost to the end. So let's give a finger snapping to all panelists from Wangda, Dorji, Laksam, Tesin, and Brian and Sarah as such a great speakers. And also finger snap to Sita and Nikos, who have been like very the person behind these webinars on advocacy and cross learning. And now let's give a round of claps from all of you that you are, because you are so fabulous. And last but not least, give a bigger finger snapping to the fabulous illegal modelings, Rain Cortez. All right, so thank you so much. Don't forget for the next webinar on 3rd and 4th will be by the last week on June. So I hope everybody can join and can learn from this cross learning and also the capacity building webinars. So see you until then. Bye.
Bye, everyone. But
Bye.
there
Thank
was
you.
one mentee evaluation
Oh,
question.
sorry.
If there's still people,
Oh,
sorry, if there's still people out
Yeah,
here,
there's
can you
still
show the
people. There's
mentee
still
for
people.
just
There's
the
still people.
evaluation question? So there's just one mentee question for you to log in or to go in. And there's just one question on what do you think is your key learning coming from this session? And that's all what we need from this mentee question. But apart from that, yeah, snaps for everyone. So if everyone was able to answer the mentee question and the evaluation question, I wish you all to have a good day, everyone.
Thank you.
Thank you, everyone.
Thank you. Bye. Take care.
Bye, everyone. Thank you so much.
Thank you.
Okay, bye, Rain. Bye, everyone. Bye.
We can stop the recording, right?
yeah,
Yes.
yeah, I think so.